Now I ask that you join me in welcoming to the podium Randall Ellis, who will be moderating our next panel, Managing Health Costs for Past and Present Public Servants. Randall is a professor of economics here at Boston University. He's served as president of the American Society of Health Economists and associate editor of the Journal of Health Economics. Serving on the panel will be Robert Posen, a senior lecturer of business administration at Harvard Business School and a senior fellow at the Brookings Institute. Robert has served as a member of the President's Commission to Strengthen Social Security, Secretary of Economic Affairs for Massachusetts, and chair of the SEC Advisory Committee on Financial Disclosure. And returning after his address this morning, I'm pleased to reintroduce David Sweeney, Chief Financial Officer for the City of Boston, who, as you heard about this morning, has very extensive relevant experience on the state and city level. Another member of the BU panel, family who will be joining the panel, David Rosenblum, is a professor at the Boston University School of Public Health and serves as chair of the Department of Health Policy and Management. Prior to coming to BU, David served as the Commissioner of Public Health and Hospitals for the City of Boston. And finally, I'm pleased to welcome Carolyn Ryan, Assistant Director of Policy and Research for the Massachusetts Taxpayer Foundation. Prior to her work with the foundation, Carolyn was a consultant with Public Financial Management, where she worked with state and local governments on financial and strategic planning. So please join me in welcoming all the panelists.
Hi, I'm Randall Ellis, and since the introductions have already been done, we will be having the speakers in the order in which they're sitting. So Bob Posen will be going first.
Thank you. So this little slideshow is intended to give background to the audience and all the panel members to shoot at about retiree health care. You've already discussed pensions, but retiree health care is sort of the hidden elephant in the room. Just to give you a sense, when Detroit declared bankruptcy, its unfunded pension plan was about $3.5 billion, but its unfunded retiree health care was close to $6 billion. So that's a pretty serious issue that's been sort of under the table. So these are technically called OPEBs, O-P-E-B, which means other post-employment benefits. They're 99% health care, so you should just consider them health care. What are they? They are basically the contributions that city and state governments make to finance retiree health care from the time that people retire, which let's say somebody retires from the police force at 50, age 50, so it'll cover them all their premiums or most of their premiums from 50 to 65. And then when these people reach 65, most of them go on Medicare. Still, many cities and states pay their premiums for Medicare, and they may even pay Medigap, which is the supplemental. Now, why has this number grown so quickly without much public discussion? Well, until 2006, there was no disclosure required by GASB. GASB is sort of like the government equivalent of FASB for financial accounting, but it has a lot less power. Now, since 2006, these numbers appear in the footnotes to the financial statement, so we're able to start to have some analysis. And there's currently a proposal to improve this reporting in several respects. One is to have a more accurate and reasonable discount rate, and another is to put this unfunded liability on the balance sheet of cities and states. Both of those proposals are likely to be adopted in the next year, and they will have a big effect both on the politics of this and on bond ratings. But, and this is a critical difference with pension funds, there's never been and there's no proposal to have any advance funding. So that means that most retiree health care plans are 3 or 4% funded, very, very low. You know, if a pension fund were that low, we would go crazy about it. But that's what it is, and therefore these benefits are paid out of current tax revenues. And therefore, as they grow, they will start to compete against school expenditures, police expenditures, et cetera. Now, give you a sense of the scope of the problem, here are a few states that are pretty big. New York is one of them. New Jersey wins the prize for the highest per capita, $7,206 per capita, and that's a pretty big number. What's interesting is that there are a number of states that have managed this down. And you can say they're smaller states, but look at the per capita numbers. It shows that they've really done a pretty good job of managing it down. So you have a tremendous disparity here in states, and in these states, this number is really gonna start to eat up the state budget. Now, cities also have big unfunded liabilities, and New York City is by far the highest. That's a bit of a statistical quirk because they include all of the teachers' retiree health care, which many cities do not. But I draw your attention to Boston, and this is about $4.5 billion. This is the, the number for long-term unfunded liability, which comes to almost $19,000 per household. And there you have it, almost zero funding level. It's actually slightly higher now. But so for Boston, this is a big number. People can debate, depending on what actuarial discount rate you use, whether it should be, I happen to think it should be $5 billion. I'm sure the city thinks it should be $3.5 billion, but it's a big number. And really, so far, it's pretty much unfunded. Again, we see that there are cities that have done a really good job dealing with this, and so it's not impossible. It's a question of what your political will is and what your fiscal discipline is. Now, as I said, this is the big negative about OPEBs is they're not advance funded. The big positive is from a legal point of view, not political, from a legal point of view, they're much easier to change. Most pension funds, many states, including Massachusetts, have constitutional protections for any change in pension benefits. That's not true of most health care, and that's a big difference. But still, they're subject to collective bargaining, and the political issues are there. In Massachusetts, these are numbers, and I have Carolyn Ryan to thank for these numbers since she's the person who knows all the data. You can see that retiree healthcare in these 4 cities is growing quite rapidly. And the property taxes are growing, but the property taxes are not growing as quickly as the healthcare liabilities. So the healthcare payments, these aren't liabilities, excuse me, this is the current spending. This trend, if you think about it over time, means that even if you continue to raise property taxes, your higher spending cost on retiree health is going to start to eat that up. And I believe this is the big political issue that will sort of get people's attention. Now, this is a Newton number. Ruth Ann is here. I'm a very courageous person. She ran for office and won. But in Newton, so you would think, I used to live in Newton. Newton's unfunded liability for retiree health care is over $500 million now. Just think about it. It's not a big city, over $500 million. This is what was spent in fiscal 2004, $21 million. That comes out to be $747 of every household's property bill. Again, that's going to become, in my view, a real political issue. Newton had an override on 2.5. They approved 8.4 million. If you look at year to year, most of that wound up going to retiree health care. What's worth? 8.1 million, the incremental money that went to retiree health care year to year over the last few years could go to 79 additional teachers. So As I said, being an unfunded liability comes out of current property taxes. There are only two things that can happen, three things. One is you increase the property tax. Second of all, you reduce other important services. And the third is you manage the retiree health care down. Now, what can you do there? It's pretty obvious that you could increase deductibles, you increase co-payments, you could have retirees contribute more, you could not cover dental and eye. There are a million different things that we can think of. The question is, what can you do? It's easy enough, I think, politically to apply this lower benefit package to new city and state employees. The problem is the benefit is 20 and 30 years off. The real question is, and second of all, I think it's very hard to apply any changes to people who are already in retirement. But the big bulk of the people are there now, and the question is, what are you going to do in terms of their benefit packages? Massachusetts happens to be an outlier in this, is that you get retiree health care if you are a public employee in many places part-time for 10 years. I think there's pretty much a consensus this should be full-time 20 years, but that went to the legislature and did not pass. So what's going to happen here? I think basically we have two triggers for negotiation. One is the Supreme Court came out with a collective bargaining decision in which it established two principles. They're based on the fact if there's an ambiguity in the contract. Well, every public collective bargaining agreement I have is just filled with ambiguities. They're subject to interpretation. And the Supreme Court said, if there is an ambiguous contract, you should not presume lifetime benefits. Lifetime benefits need to be explicit. They are not explicit in most contracts. Second of all, if the collective bargaining agreement ends like 3 years, 5 years, 10 years, then you should renegotiate the benefits. So that's pretty much, I think, a clarion call to cities and public unions, and I really think it's a great thing if they start to negotiate and get this all on the table, make it explicit, and decide what they're going to do. The public union should be worried. These are unsecured creditors. They are unsecured creditors. In Stockton's bankruptcy, the bankruptcy judge allowed all retiree benefits to eliminate it. Not pension benefits, but retiree. So if I was a public union, I would trade some smaller package for some actual funding, advanced funding, that would mean that you'd actually get it. A second thing that's going to happen is under the ACA, the Cadillac tax. The Cadillac tax applies in 2018. It applies to any family of four where the premiums exceed $27,500. If you look across the country, most of the plans that are going to exceed that amount are public plans. They're city or state plans. New York City estimates now that in the year 2023, it will cost them $500 million to pay the Cadillac tax. The Cadillac tax is 40% excise tax. That's one hell of a tax. In Washington State, the municipalities there are 16 of them that have a pooled plan. That for them, it's going to be $73 million. So these are big numbers. But some state, I think Rahm has already done it in Chicago. A number of states and cities are trying to figure out how to push their people onto the connectors in their jurisdictions. That is one obvious advantage. The people on the connector get federal premium subsidies. So it's a way to shift costs from state to federal. But just think about what you're doing. You're essentially taking cities like Chicago that have been irresponsible, and you're getting them a much bigger federal subsidy, which is being paid by cities and states that were responsible. That's effectively what's happening. And I don't know whether politically that's going to fly if that starts to happen a lot. So basically, unfunded OPEBs are rising quickly. The new accounting rules are going to focus this. They have less legal protection. They're not constitutionally protected. And the combination of this Supreme Court decision and the Cadillac tax will mean that we're very likely to have some bargaining out in the open and for these packages to be dealt with explicitly, and the politics of this really on the table, and people can decide whether they want retiree health care or other services, whether they want property taxes or other services. We're coming out of the out of the age of silence here into the age of transparency, and I think it'll be a good thing. Thank you very much. Left my glasses here.
Thanks again. I'm Dave Sweeney, CFO for the City of Boston. And in listening to everyone this morning and early this afternoon, I think what I'm about to talk about is a good illustration of some of the themes that we've heard throughout the day, especially talking about when it is that cities and towns receive the tools that they need from higher levels of government in order to make the changes necessary to make themselves or maintain their fiscal viability. Also, I think this is a good illustration of sort of mixed results, even with a pretty aggressive approach to tackling a major problem in the City of Boston's budget. And lastly, I think it's a great illustration of the vigilance that I tried to speak to a little bit this morning in my opening remarks that is necessary in order to maintain fiscal stability. So first off, this chart shows the cumulative growth from fiscal year 2001 through what we're projecting for the fiscal year 2016 budget for the City of Boston. As you can see, the growth was on a pretty steady yet steep incline from 01 all the way up until fiscal year 2013, and we'll get to a little bit of the reason for the eventual dip soon. So we were spending $123 million on health insurance premiums in fiscal year 2001. We're projecting $296 million in fiscal year 16, and I think this probably resonates at least with my colleagues in Massachusetts, if not across the country. From 2002 through 2007, the average annual increase was about 11.4%, which with our annual increase peaking at a little over 25 million during that period. Needless to say, this far outpaced revenue growth and necessarily cost growth in all other city areas, with over that 15-year period, city costs and other non-health insurance city costs increasing by 66% and health insurance costs increasing by an estimated 141%, accounting for the FY16 budgeted health insurance figure. And I think to further make that point, our health insurance premium appropriation continues to constitute, well, at least for a period of time, grew to constitute a higher and higher proportion of the overall city budget, from 7.1% to a peak of over 12% in FY12, before settling at between 10 and 11% in each of the last 3 years. And actually, it's really steadied out over the last 2 years, maintaining an average of 10.4% projected. So I guess that begs the question of what happened toward the tail end here in FY13 through FY16, and essentially it was a combination of factors, in essence brought on by the Great Recession and tools being given to the City of Boston and the other 350 cities and towns in Massachusetts. Municipal health reform was approved in 2011 after decades of feet stomping, frankly, by municipal officials, think tanks such as Mass Taxpayers Foundation, clamoring about the uncontrollable growth in health insurance costs for cities and towns, as well as at the state level. During this period of time, the cities and towns were given not only this tool, but other revenue-enhancing tools as well. We were given municipal local option meals tax, and an increase in the local option hotel motel excise tax as well. At the same time, the state enacted legislation to reform pensions, healthcare payment reform, transportation reform, ethics reform, and others. But essentially, this specific reform, approved by the state in 2011, increased the city of Boston and other cities and towns' flexibility to negotiate health insurance changes with their labor unions, while also allowing, if deemed beneficial, there's a lot more, obviously, that goes into this in terms of the details, but it did allow some cities and towns the ability to join the state's group insurance commission, which requires employees to pay a much larger share of their overall health insurance costs than they are required to in the city of Boston and probably in most cities and towns across Massachusetts. So in essence, this reform was enacted after years of pressure from cities and towns and from outside, mostly business-sponsored groups. And it was basically a recognition of a 37% unrestricted general government aid cut from 2008 to 2012. The state's solution for most of these years was to attempt to offset local aid cuts by offering tools that could achieve comparable savings in each of those years. And that was done in several phases, and I think the ultimate reform that was most beneficial to us was the municipal health reform law in 2011. So Boston's experience was a little bit different. So this slide says Boston's first PEC agreement, and PEC stands for Public Employee Committee. The city was actually able to come to an agreement to achieve significant savings with its labor unions in advance of the legislation actually being enacted by leveraging the sort of imminent enactment of the legislation. So when we negotiate health insurance now from 2012 forward, and hopefully forever, but at least until 2020 now, we negotiate as a city with each of the city's 39 public employee unions as part of one committee. So we come to an agreement on all aspects of health insurance coverage, plan designs, co-payments, deductibles, premium sharing, and any other ancillary components to the benefit with all 39 unions in agreement, including the teachers, police, fire, and clerical administrative workers, anyone you could think of basically who's a city employee. So the first agreement, we're now projecting it to have generated $59 million in savings over 4 years. The main factor in that was basically a 2.5% employee premium share increase phased in over in two phases, as well as co-payment increases for a variety of different services. In addition to these measures, which are largely cost-sharing and cost-shifting measures that labor agreed to, other initiatives have been undertaken to attempt to mitigate cost growth and to achieve cost avoidance. For instance, working with labor, we've eliminated the most expensive medical plan. We've also moved to self-funding for the overwhelming majority of our plans. Sort of cut out the insurers. We have implemented limited wellness programs, and we're on the verge of selecting a new one in sometime in the next year in all likelihood. And we've also taken the opportunity to achieve administrative savings through initiatives such as a dependent eligibility audit. We're still finding that there are opportunities administratively to clean up our data that are going to lead to large-scale savings in the future. But that said, as I alluded to, health insurance pressure still remains. So for 2016, 10.4% of the city's $2.9 billion budget is being consumed by health insurance premiums, and the city's most commonly subscribed HMO plan costs almost $19,000 for a family plan. As I said, well, so after our first PEC agreement is scheduled to expire on June 30th. We've now agreed to a successor agreement with our PEC that we estimate will save $45 million over 5 years. We'll go through that really quickly. I know I'm running out of time. So $45 million over 5 years with a 2% employee premium share increase. That also 2% increase from 16 through and in 18 on the Medicare plans as well. And also additional primary care and specialty copay increases. We've also tried to get creative in implementing other changes that we believe will lead to savings going forward. For instance, with the impending excise Cadillac tax in 2018, we've built in provisions into our agreement that if the Cadillac tax does in fact take effect, which I think is a point of dispute depending on who you speak to, we have what amounts to reopener language to renegotiate and decrease the actuarial value of plans offered in the event that that occurs to avoid the Cadillac tax, which if implemented at our current plan values would cost us about $3.5 million a year and is likely to cost us about $6 million a year by FY18 at the rate of growth we're anticipating. We're also able to reduce the number of plans by half, essentially, and go out to bid for new plans, which are going into effect. We're in our annual enrollment period now. They'll go into effect on July 1st, 2015. That's the first time that's been done in the city that anyone can remember. And we're also going out to bid for our Medicare plans and potentially for a prescription drug carve-out in 2018 as well. So I think that's about all I have, as I'm out of time.
Thank you very much, and I thank the sponsors for inviting me because it's a personal pleasure to participate in an event that is so clearly in the spirit of what Tom Menino had in mind when he came to BU shortly before he became ill to create the initiative on the city. So it's a pleasure to participate. Since it's the afternoon session right after lunch, and many of you may want to take a nap, let me get to the bottom line of what I'm going to say in the next 10 minutes. And that is that I think cities have actually a limited capacity to really do an awful lot about changing the slopes that David Sweeney demonstrated just a moment ago. I think they can and do shift cost, but shifting cost to the workers or somebody else is not the same as really cutting the cost of health care. Let me start by saying that employer-based health care really started in this country with the teachers' union and hospitals in Texas during the Depression, grew rapidly for large employers during World War II when they were not able to raise wages, and so employee benefits became a substitute for wage increases, and rapidly after World War II spread to all employer segments. And what started out as community-based rating, everybody in the same community paid essentially the same rates, devolved to experience-rated groupings, so that the private insurers came along to compete with Blue Cross and said, you know, Mr. or Miss Employer, you really ought to pay just for your group. And we'll probably be able to save you money if you pay just for your group. And that's where we are today, and that's why municipalities are in big trouble with their health care costs. Because by and large, municipalities have a terrible risk group. Their employees tend to be older than average employed groups. They tend to stick around longer. They are of longer duration. They have low turnover rates. They are engaged in higher risk occupations than is the typical employer group, police, firemen, manual laborers. The total employee workforce is modestly paid. There are more families with dependents in municipal workforces than there are in the general workforce. And the sizes of the group have been, in general, shrinking or at best staying steady. That all adds up to a rather adverse risk group. And so when we think about the Cadillac tax threat that David and others have alluded to, that Cadillac tax threat is more associated with the health risk of the groups of employees that cities have than with the plan design. And since the tax is based on total cost rather than actuarial value, screwing around with the plan design may not actually affect the total cost, because what's driving the total cost are those health factors and the group factors that I described a minute ago. Some major efforts have been made in Massachusetts, and David referred to them, and so I won't spend much time on them other than to say that the reform in Massachusetts said that you could take out of collective bargaining changes in deductibles and co-pays within certain limits guided by what state employees were getting through the Group Insurance Commission. Premium splits remain subject to collective bargaining, as David demonstrated has happened in Massachusetts, in Boston. People who are eligible for Medicare must now enroll in Medicare. It's easier to shift employee groups into and out of coverage in the state Group Insurance Commission, which is a very, very large statewide group. And the law really encouraged more competitive bidding by insurers, and as David said, saved a lot of money immediately, but then you see that growth curve begin to come back up. So what can municipalities actually do to save money? I think not a great deal, because they are not in essential control over many of the levers which are driving their total cost. Total cost in healthcare is the sum of the units of service that people use and the prices that get paid. If you control price but not units, total cost is likely to continue to go up. And so controlling one part of that equation is a problem for any single group plan, almost no matter how big it is. And so I think there really are limits on what individual employers like cities can do. They can raise deductibles. And when you raise deductibles, you almost by the dollar reduce premium. What you are doing is shifting the risk to the employee, I'm sorry. The employee is paying a lower premium along with the employer, but bearing a larger risk for that first set of expenditures. And so you're not really controlling total expense, you're shifting the risk to the individual employee when you raise the deductibles. You can raise co-pays, and there's very clear evidence that when you raise co-pays, you reduce utilization. The problem is we don't know whether you reduce, the problem is the evidence is that you reduce utilization that is really important for maintaining your health or controlling the development of your disease, about at the same level as you reduce unnecessary stuff. And so co-pays reduce utilization, but not necessarily in ways that improve the population health or improve individual health. And so you may, in the short term, reduce utilization, and in the medium term, add to the greater cost of the individuals. And since municipal groups tend to stick around, something which is very attractive to an employer whose turnover is going to be 100% in 3 years, because they won't have to pay the long-term consequences of co-payment utilization that didn't occur, and therefore you get sick 4 or 5 years from now, you're going to get sick on somebody else's insurance program. But in the municipal employee group, those people are going to be around for the municipal employer, and that's why those costs are going to continue to go up, in my judgment. You can try to get into a larger risk pool. Since most municipal groups are adverse risk pools, if you get into a very large group, like the Group Insurance Commission, you might in fact be able to reduce your risk over a period of time. No guarantee. There's some generational change taking place at the moment, which is why Bob Posen is so concerned about the post-employment benefits. So in some cases, municipal employee groups are in fact turning over, and there's going to be a younger, lower risk population, and that could happen. But by and large, the risk pool business is a problem. Wellness programs are being promoted as a way of controlling or reducing costs. There is simply no evidence that that works. I think that most employer groups have been sold a bill of goods by their consultants, many of whom sell these programs. There is simply no reliable, consistent, long-term academic evidence that any wellness programs have any deterrent effect on long-term health trends. And many of these wellness programs have as at their core penalties for certain kinds of behavior. And so we are now having wellness programs authorized under the ACA in which you can penalize people who smoke by charging them higher premiums. I think that is the beginning of a very slippery slope. Addiction is a disease, and I think that if we are able to charge higher premiums to people who smoke, or if we can have employment rules which say we will no longer hire anybody who smokes, I think that we are starting down, my judgment, a very slippery slope. We can provide incentives to employees to enroll in lower-priced networks. If those lower-priced networks do not control utilization, it is conceivable that you will have greater total expenditure because the price per unit goes down, but the number of units purchased goes up. So if you have a tightly controlled primary care network in which the owning hospital makes sure that every possible CAT scan gets ordered and done, you run the risk of total expenses going up even if the price per unit is down. You can encourage your employees, you can set up contracts for real capitation and real global budgets in which the providers are at genuine risk for containing the total cost of health care, and the employer group actually has a fixed known upside risk. The problem in towns like this is that the health industry is a huge employer. The health industry is, in fact, a significantly larger employer than the municipal government. And so there really is not yet an appetite for genuine risk on the part of the providers. The global budgets which are now being put out are, in fact, attempts to slow the growth of expenditures, not control in any way the total risk of expenditures. So global budgeting has been tried in other countries. It's effective in other countries. We really have not gotten serious about it in this country yet. Thank you very much for this opportunity.
Those were not my slides. I'm not an engineer. Thank you. Hi, I'm Carolyn Ryan. I'm with the Mass Taxpayers Foundation. Thank you for including me in this. It's been a great conference so far. I've really enjoyed hearing all of the different perspectives. A lot of what I was going to talk about has already been covered, so this is going to be a little bit on the fly rather than repeating what you've already heard. I think, for one thing, again, we've heard this both in the context of pensions and in OPEB, but what we see with these legacy costs, and when I say legacy costs, I mean the cost for obligations that cities have to previous employees that have already been promised, employees or retirees are expecting them, and we're just paying for them now. If you look at Massachusetts, we have something called a foundation budget. And what that is supposed to detail adequate spending in a school district to provide an adequate education for all students in Massachusetts. And we include contributions towards unfunded pension liabilities and contributions to retired teachers' health care as part of our foundation budget. Healthcare specifically was about retired teachers' health care was $405 million for fiscal 13. And so $405 million of our foundation budget, money that's supposed to go to providing an adequate education to today's students, is really going towards legacy costs, towards yesterday's students. And I think, again, that just illustrates the sort of tension of paying today for yesterday's costs. I'd also underscore the Cadillac tax that people have already touched on. It seems like there's some disagreement over whether it will become a reality. I don't think you can plan hoping that it doesn't become a reality. You have to plan as if it will be a reality. In Massachusetts, a number of municipal plans and at least one state plan, if they're not already at the threshold, are bumping very close to the threshold. The state level, conservatively, it's an 8-digit liability. And one of these things, the Cadillac tax, if you're a self-insured plan, which many municipalities are, the insurer is responsible for paying the tax. So that falls directly on the city. And I'm not sure that's something a lot of municipalities are aware of. So I think what's most useful to think about is what can cities do in terms of healthcare costs. I think everybody agrees healthcare costs are a problem across the board, private employers, public employers. It's an issue we all have. One of the things that, again, seems to be an issue both public employers, private employers, is engaging and educating employees in their healthcare decisions and their healthcare costs. Most of us probably know our co-pays for a doctor's visit, but we probably don't know what the insurer is actually paying for that visit or what the doctor is actually charging for that visit. We may know we can go to any one of 3 or 4 local hospitals for an x-ray, but do we know what the cost differences and what the quality differences of that are? So that's something I think broadly that we can look at in terms of managing costs. I would say that cities now getting back on the Cadillac tax, taking action now is something they have to do. I think Boston's solution is an interesting one, having a reopener so that if it does come up, it's something that can be addressed. I'd also like to see more cities account for the full cost of compensation with their employees. So when they're talking about having new hires, not just looking at salary or even just the cost for the active health plan, but thinking about how much it costs to set aside for the cost of retiree health care and pensions and any other types of non-salary and wage compensation there is. I think sometimes municipalities overhire because all of those things aren't taken into account, and then a few years down the road, they've consumed more than they expected in terms of costs. And then just the last point is, I think from the taxpayer perspective, what we would like to see is more transparency and more information on data in terms of how your healthcare spending line items and your retiree healthcare liabilities. Bob again touched on that these are a fairly new item that's being reported in financial statements, and information is somewhat limited. I know from some research that I've done, it's very difficult to get. It's still not uncommon to call a local budget office and ask if they have any data on their retiree healthcare or OPEB liability, and they'll say, what? And that's definitely a local issue. Massachusetts is a little unique in that we have 351 municipalities of all sorts of sizes. So that may not be as much of an issue for places that tend to have bigger governments or regionalization. So, I mean, I think I'll end with that. As I said, much of what I would say has already been said, and I would echo things that everybody has said so far. And, that's it. Thank you.
Great. So I appreciate that my speakers all stayed in their time allocations, and so we have some time. I wanted to start by allowing each of them to react to some of the things they heard their fellow panel members make, and then we'll open it up to questions from the full audience here. Bob, did you want to make any reactions?
Yeah, my reaction is I'm congratulate David Sweeney on the work that he's doing, because I know how hard it is to bring down costs. He's clearly going in the right direction. I believe that David Rosenblum is a little more pessimistic than I am, since he basically seems to think there's nothing you can do, or more precisely, that these healthcare costs are determined by larger forces. Obviously, he's partly right, but I do believe that it is feasible to manage down some healthcare costs. If you increase copays and deductibles, and you do it in an intelligent and well-designed way, you can get people to do less unnecessary visits. Obviously, if you do it poorly, you'll get more visits. I think preventative health care can be used in certain areas and not in others. And I think the reality is we have never gotten to the point where most citizens actually have any idea what they're paying for health care. So for those people who believe that consumers can make intelligent choices and keep their costs down, I don't know, we don't have an experiment. When I was in state government, we passed the individual mandate. There's a requirement that all this transparency, but you try to find that transparency. Carolyn probably knows data more than anybody else. So I think I wouldn't be as pessimistic as David Rosenblum, because I don't think we've given a lot of these things a fair chance.
David, a few comments?
Sure. I would just add, I agree with Bob, and I also agree with David to some extent.
That's why you're sitting.
Yeah, I think it's I think it's maybe an overlooked aspect of this, though, that there is some degree of inevitability in the growth, no matter what tools we have in terms of cost shifting or administrative savings. That the health trend rate is still 7 to 10% that we're looking at from year to year, and we have very little control over the primary drivers of those increases. So I was kind of trying to get through my presentation, so I maybe didn't hit on all the points I otherwise would have, but I guess the conclusion to that 15-year story in the charts that I had was just that after 3 years of, we actually had a couple of years of overall decline in our health insurance premium spending, but now going into FY16, we're projecting a 4.5% increase again, despite all of the changes that we've made that amount to, and I also didn't get to $20 million a year in average savings just from eligible retirees being forced to move to Medicare as well, which is a huge piece of this. And despite all of that, we're beginning to see increased year-over-year appropriation requirements resume. So I do think there are things we can do, but as I was alluding to, it's mixed results, even with what we believe is a very successful story of a state giving us tools that we need to succeed, and us taking as much advantage of them as we possibly could through a cooperative arrangement with labor, and yet we still it still requires the constant vigilance I was talking about to continue to manage those costs from year to year.
I'm rarely cast as the pessimist. I would rather say that I'm trying to take a realistic view. And I think that if we look at the nature of the municipal workforce, we see a group that's going to be high utilizers of medical care, and the control of the municipality over the levers of that medical care is really very limited. And so that's sort of the dilemma. And I think that it is far easier to shift cost than to cut cost. And when we're shifting cost to municipal employees, we're cutting their pay. as we are with other employers as well. And so I think we just have to be realistic about that. And you know, in all due respect, I think the concept of managing these costs is to a very large degree a euphemism for shifting cost. And we're shifting it largely to our employees. And I think that that has a limited prospect.
Carol?
I would agree with what David said, that increases are inevitable, and that's certainly true. I think when you look at the problem of OPEB in Massachusetts, and this is probably true in other areas, but I know Massachusetts the best, so that's what I'll talk about. But the magnitude of the increases are not necessarily uncontrollable. We have such generous eligibility standards, such generous benefits. Full benefits at 10 years of part-time service is extreme. You know, to get lifetime health care after essentially the equivalent of 5 years of full-time work is an excessively generous benefit. So we do have some control over the OPEB costs and over that. I think you're right. There's a certain level of growth that's going to happen for active employees, and that's part of a broader conversation on healthcare that I think is outside of the scope of this panel. And I want to be clear too, we're not advocating by, in some of the Mass taxpayers' previous works with municipal health reform, we've never advocated to cut benefits or not provide the benefit or provide an unreasonable level of benefit. I think what we're looking at is fairness to both the taxpayer and to the employee, and then fairness within groups of employees.
I was struck by some of the comments about features of cities that make them different. And one feature I know is that almost every major city has a large hospital, and that means they have expensive care, very accessible to a lot of their residents, which does tend to mean that they pay higher prices, the hospital negotiates better rates. And so I'm interested in the question of whether there are advantages to cities to joining larger coalitions such as the Group Insurance Commission, which broadens the base of people lobbying for cost containment, because it may be very hard for cities to bargain for reduced payments or cutting on spending on their own favorite hospitals and medical centers.
Well, I have advocated several times that there be differential copays depending on what hospitals you go to. And we know that MRIs cost twice as much at Mass General than they do at Newton Wellesley. And Newton Wellesley does a pretty good job. In fact, I'm sure there's some differences. But even if you don't have that, I'm saying even in Massachusetts, it's very concentrated. There are many services where the difference in hospital costs is huge. And if you just, what we know is a difference of $25 in a copay will change people's behavior. And it's probably the same machine at Newton Wellesley as it is. Of course, and in the end, the doc looks at it and there's some this and this. But I think, I don't know how much it moved, but I don't think even, I'm saying that even if we don't restructure cities and their hospitals and academic centers, which I think is pretty tough, there's a pretty simple way to do it. You know, say you pay $75 copay if you go to Mass General, you pay $25 if you go to Winchester or Newton Wellesley. You'll change that behavior pretty quickly.
One other comment as a health economist, I can't resist mentioning that the latest American Economic Association meetings, there was a discussion of the slowdown in medical spending. The consensus of the serious modelers is that most of that decline is explained by the recession, not necessarily a permanent trend change. And it may seem odd that the timing is so much later than the depth of the recession in 2008 and 9, but it may be that hospitals avoided building new surgery wings and others during the depth of the recession, and now they're going to pick up again. Is there anything fundamental that we can point to that's actually changed, David?
No, I don't think so. I think that there has clearly been a slowdown. I think there were numbers of factors. I think we're seeing a bit of a pickup now, which is why the city of Boston, despite, I think, terrific efforts, is going to see outlays increase, and I think the rest of us are as well.
Why don't we open it to the floor now for some questions? I see one over here, and also then next. Thank you.
Hi, thank you. My name is Mike Butler. I live in Dedham, which is a town of 25,000, about 10 miles southwest of here. This is also the 40th anniversary since I graduated from BU. So nice to be back. I have a comment, and then an answer to a question from our friend from Toronto, and then a question for Bob Posen. So first, small town, 25,000. Our pension is 80% funded. Our pension is 80% funded. We expect to pay it off in 2024. When we gather again here in 9 years, I'll give you an update on that. Our OPEB, we have fully funded our annual required contribution on OPEB the past 3 years. And we did that because under Massachusetts municipal healthcare reform in 2011, we had more financial flexibility than a lot of other communities. So we plowed those savings right into OPEB. That has put us in a good position. So we're about 10% funded. We'll pay that off in 2043. Our actuary first did our calculation of our unfunded liability in 2008. It was 112 million then. Today it's 55 million, only because we've made the commitment to fully fund it. So we've seen some good dramatic decreases in our liability, and I think a lot of communities might not recognize it. If they actually get to the ARC, their liability drops quite a bit. Our friend from Toronto, what we do is, you know, we talk about ARC for pensions, so we have an ARC for OPEB. We have an ARC, an ARC for sewers and roads and buildings. And that's how we talk to our residents. We say, how many potholes do you want? Because the less you invest, the more potholes you have, and vice versa. How much water do you want leaking into the sewers, which you then pay the MWRA to treat? And then how old do you want your school buildings and your municipal buildings? Because they all have a life cycle. You just do the math, it's pretty easy. So for us, roads is $2 million a year, sewers is $1 million, buildings are $5 million a year. So that's my comment. Then my question for Bob ties back to Mayor Tavares's efforts to communicate. He had to work really hard to communicate the unfunded pension liability, right? And I really feel that we as a group are ill-served by our financial statements. So the GASB changes for pension and for OPEB are really gonna help quite a bit, right? But it's gonna take time. Because right now they're hidden in the footnotes, footnotes 11, footnote 22. And a couple of months ago, you may remember an economist said, people are stupid. They're not. We all know that as elected officials. People are smart. They understand revenues and expenses. They understand assets and liabilities. We don't do a good job defining.
And there's a question coming, please.
Do you feel that the GASB requirements go far enough for pensions and OPEB? And do you feel they ought to also look at redefining what a balanced budget is?
Well, I don't think they go far enough, but I think GASB is constitutionally and politically in a much weaker situation. And I think the first thing that GASB ought to do is to start to require over any longer period some advance funding, because as you say, advance funding really dramatically changes the situation. But maybe more fundamentally, we need to translate these deficits into things like, this is how much, if we do this funding for these plans, it will cost us X amount per teacher, Y amount for policemen. I think that's actually the only way that people understand this, and it has meaning for them. Another way is to say how much property tax is going to these things. Those are the things that I've found are meaningful to people. Most people don't read footnote 22 of even the wonderful Dedham financial statement.
Yes, I'd like to recognize the woman in red. Yes?
My name is Paulette Ngashoku, and thank you for the information you've already shared with us. I want to make a remark. When you ask a plumber to come to your house, I think that plumber is able to give you an itemized bill, you know, the price of their services, the material cost X, they tell you it's $1. If their hourly, you know, compensation is $50, they will tell you that. Whose responsibility is it to make sure that people are well educated about the cost of their healthcare? Are the cities doing enough to educate their people? Are healthcare providers disclosing enough of the information? And what would be the effect of transparency on the cost of healthcare?
I don't know if anyone would like to answer that. I'll also comment that a wonderful thing in Massachusetts is the law that enables patients to ask their doctors and hospitals, what is the price of the service that you have just recommended or I've received? I have done that when I see my own primary care doctor, and he says, oh, I didn't know I had to give you that. You have to go see my billing clerk and wait in line, and then they'll send it to you, blah, blah. We have to make that easier. But at least it is the law that you can ask to get a detailed, itemized list of your prices and services here in Massachusetts. I don't know if others have had experience with that.
I think that pricing is so opaque
Yes.
that you ask a very reasonable question.
Yes.
And it is opaque because both the providers and the insurance companies have found it to be in their economic interests to keep it opaque. And I think that until that transparency is developed, they're going to continue to be opaque. And we now have, Randy is correct, we have the obligation in Massachusetts to have prices on a website. And there is no evidence that consumers are yet looking at that. Randy is not a typical consumer. But there's no evidence that we are actually taking advantage of information which is now being published on quality and to a certain degree in Massachusetts on price. If you are in the emergency room and in significant pain, the odds of your looking for the lowest bidder are very low. So it's not clear that price transparency is going to change a lot of behavior quickly, but I can't believe it won't help. And the reality is, in the United States, it is the difference between the United States total cost and most other countries is price, not utilization. And so I think if we got price clearer, maybe it would begin to affect providers' behavior, if not consumers' behavior.
The woman in blue here, who has the microphone?
I'm Kim LeBlanc from City of Manchester, New Hampshire. We recently, in the last several years, had instituted an HSA plan for our employees. I'm wondering if you're seeing more of a trend of that and if there's really cost savings.
This is a health savings account, which has been enabled since around 2007, I think. I've done some work on health savings accounts, not a great deal. They are in the direction of encouraging individuals to shop around and find lower price and higher quality providers. The challenge is precisely with the lack of transparent prices, it's almost impossible for a consumer to shop around if they don't know the prices of their own doctor, let alone of the ones that they've never met. And there's some evidence, unfortunately, that if you don't have an insurance company negotiating a lower price, then you're more likely to be overcharged by your doctor or hospital. So the health savings accounts, although seemingly attractive, don't actually encourage the hospitals or doctors to discount the prices to you. They may realize that you don't really know what the alternatives are.
I also just would make a point on that this reminded me on the health savings accounts, other tax advantaged healthcare spending accounts, flexible savings accounts. In HRAs are still a little bit of a question, but these are all part of the Cadillac tax, both in terms of getting you to the threshold or over the threshold, and then being subject to the tax. I think, again, that's another less common known aspect of this, but in some cases that could be what pushes employees' amounts over.
I saw a hand over here. Thank you.
Good afternoon. Darrell Jones, controller for the City of New Haven. It's interesting because we're a little different in terms of what we're doing. We're self-employed for our health care. It's about 15% of our budget. There's definitely,
when you say you're self-funded,
we pay for
Self-insured.
self-insured. We pay
so
for
does
everything.
that
Sorry
mean
about that.
does that mean you
We pay for all the bills.
you hire TPA and then you buy stop
We have
loss
administ-
insurance?
We have an administrator, and we pay for our costs.
Okay, you pay for your costs, and do you have stop loss insurance?
Yes, we do.
I see. Okay.
But that doesn't stop the fact that we, when we have that preemie, that shoots up our costs. That was one of the questions, like how do you deal with that? Because we can pretty much track, we see what our costs are, but it's those one time that gets us at $1 million or $2 million. We pay for that outright.
Yeah. So I've actually about to publish a paper on self-funding, and it's a very complex market. It's dominated, this stop loss insurance, by the largest reinsurers in the world. But the good news is that you can negotiate not just an aggregate coverage, if your total costs go above a certain amount they pay. You can negotiate that if an individual employee's costs go above a certain amount, they will pay. Now, of course, it's all in the premium, but I'm saying is I believe that that's a good thing to do when you negotiate stop loss insurance, because sometimes that's the thing that really undermines your whole plan. Just one or two individuals, and they will give you that type of stop loss insurance if you pay for it.
One other question. It's interesting because we do wellness program. We have Yale. We actually got Yale because 70% of our employees actually go through Yale.
Well, that's a big problem in terms of cost, because all the doctors at Yale, and I went to Yale in graduate school, are all geniuses. They'll tell you that.
Right. It's funny. We kind of.
It's all the Harvard people too. So when you have all these geniuses, they charge you a lot.
Right. We're kind of holding them accountable with our administrator and the wellness program that's part of Yale. We looked at that as one way to address some of the issues. It's funny. And then we have HSA. We started that with the firefighters. We're working with that. They're very resistant to it, but I think down the road that's going to be it's going to be a huge benefit to at least the city. The one question I have is and it was interesting. My budget director and I have been working on, why don't we just get out of the business and just, hey, listen, we're going to give every employee $20,000 and you go to it, because when you put the ownership back in the employees' hands, now they're going to start thinking about how they address their health care. Because for the city of New Haven, we have very poor health for our employees are in poor health, in other words. They're some of the sickest people that we've seen, and we're like, how do we address it? Because we know our costs are going to keep rising. So, one thing, do we just get out of the business and just pay everybody $20,000? And going back to that one question, co-payments, we found that we do look at what the doctors charge us. And we found that the same doctor has two offices in different parts of one in North Haven, one in New Haven, and they charge two separate prices. So we're actually going after on that. So if you need a surgery, you go to North Haven, it's going to cost you $20,000 more versus doing it at Yale, which is actually cheaper. So we're going after that. We're kind of tying into finding out, and transparency is all about.
If you gave each employee $20,000, and Carolyn can tell me if I'm wrong. First of all, that would be taxable income to them, right. And second of all, you would be subject. People don't think of this, but cities and states are all subject to ACA penalties. So you wouldn't be offering a qualified plan. So you'd be surprised what it would cost you and cost your employees if you did that.
I think the question is whether it will be expanding the exchanges so that becomes an attraction option. No, I think it's too early to know what direction that will go.
But I think even with the exchanges, the compensation would be taxable. So it could, in some cases, end up being a pay decrease if the additional
even
compensation.
Even with the exchanges, you're still going to pay. The city's still going to pay the penalties, because anybody who goes from the city who gets a premium subsidy is going to cost you $2,000, or if you have no plan, it's going to cost you $3,000 per employee. It's going to cost you a lot of money and your employees a lot of money. Whether it costs you less or more than $20,000, I don't know.
And with regard to your first point about, I guess, managing against risk when you're self-insured, obviously one tool that we use is a high level of reserves that have been as high as 20% in our healthcare trust. And then also to your question about paying employees, I don't know if you have opt-out provisions, but we have opt-out provisions in Boston where I think it's currently $2,000 you can receive if you receive your health insurance through your spouse or some other entity. But
all of this speaks to the size of the group and the risk of the group borne by your municipal employees. And the larger the risk pool, the more you spread those risks of that individual high cost. I agree with Bob that you can certainly buy individual stop-loss insurance, and that is probably a good idea. I can say that under current law, Bob and Carolyn are absolutely right that it would be very hard to do what your fiscal advisor is doing and say, let's get out of this business. But I got to tell you, that question is being raised. And if you treat employee benefits simply as another form of compensation, I think that discussion is going to get open, because the larger the pool that you put your employees into, the wider you spread that risk.
Right. I think we have time for one more efficient, short question.
No one takes the risk.
Well, I'll take this as an opportunity to say that I think the Cadillac tax is the new wild card that's in play for cities and towns. And it will be very interesting to see whether that forces the negotiations with unions and public employees to dramatically change so they're aware, gee, we don't want to be the highest cost plan. And I predict it will also cause a reduction in the variety of plans offered, because part of the reason you get a Cadillac plan is because you have some other plan that's less generous, and that brings your average for that group that's healthy out of the pool that has the Cadillac plan. So I thank my panel for this discussion, and I thank the audience for their great questions. Thank you.